Welcome to Budgeting for Health in Devolved Settings, recorded in November 2019. This is our final podcast in our series of 6 on leveraging public financial management for better health.
Now I would like to introduce our speakers. We are very pleased to welcome Srinivas Varazada, Srini, who is a Senior Financial Management Specialist and Governance Sector Team Lead from the World Bank Group and an expert in public financial management, governance and accountability. Martin Sabinoso serves as Senior Advisor at the Inter-American Development Bank in Argentina, and he is also an independent consultant. Kenneth Munge is a consultant with the World Health Organization.
The key message from my presentation is that what is important and what can go wrong is the way devolution takes place. Budgeting, it's not necessarily because of budgeting. Budgeting has its complexities when in a devolved settings, but the good news is they are not really insurmountable. We can always move forward and handle the budgeting challenges. It is the fundamental structure. The way decentralization takes place in most cases is the bigger challenge, and budget is always there to help. When we talk of the service provision in health sector and the compact of the citizens, so it's the decentralization comes in this space between politicians and policy makers and on one side, and the citizens and the service providers on the other. So to what extent system is decentralized or devolved primarily depends upon the politicians and the policy makers and the way they would want the structure to function. Here we are, with some basics. All of us know that devolution is possibly the more higher form of decentralization. So if we compare devolution with what is deconcentration and delegation, in case of deconcentration, what you're transferring is the responsibility, but the authority still remains with the central government. In case of delegation, the responsibility may move a little bit more to the lower levels of government, or the semi-autonomous agencies, but still the control is with the government on through contracts, typically like a healthcare fund. It's in the case of devolution where powers, which means the money, power, tax, as well as the expenditure and decisions of expenditure all go through the local government councils or other agencies, whichever is the lower level. It can be provincial, it can be further subnational into local governance or agencies. The key in devolution, success of devolution is like how well the political and the administrative structures are aligned to devolution. So the budgetary part of it is a small piece of this bigger puzzle. The budgetary piece talks of how well the intergovernmental fiscal architecture is developed, which means to what extent the local governments, the authorities responsible, for example, to health sector, are in a position to, one, get resources from higher levels of government, two, get their own get their own taxation resources, and take decisions on service delivery. And also part of it is the borrowing power. So that part of it is the budgeting at the decentralized level. But more important for this budgeting to work is the political decision making. Did it really move down? Are health user committees effectively working at local level to make these decisions effective? And how is the civil services and the payroll aligned, the administrative structures in position at a lower level, at a decentralized level? So budget generally is a political document. So it depends, like when you talk of budgeting in a devolved setting, who prepares the budget? Obviously, the level which is closest and which is implementing is expected to prepare the budget. And can it be health budget? Health can be a subset of a broader budget. Usually, if you are decentralizing, devolving function to local governments, say urban local bodies like municipalities or local councils as such. So it's the constitution and legal structure which defines how they prepare their budgets. Budget is a political document. It's not an administrative document. It indicates the political priorities and policies of the government of that level, that is at the decentralized level. Typically, if we take example of Nigeria, each of the states have further decentralized to the further subnational levels even within the states. So which means between states there would be variations in the priorities, and further down the agencies which are implementing at local government level would have local level decision making on budget process. So how difficult is this budgeting at local level? It wouldn't be very difficult, simply because when compared to the central level, the complexity at a local level would be lower. The budget format usually is simplified. The chart of accounts in many countries, for example, in India, the chart of accounts of Government of India gets extended for accommodating the local level codes of devolved level, which means that the third tier of the government, at the local self-government, there are codes available to be where the local governments will formulate their budget and do their accounting process. And approval process obviously is at the lowest level. Is the legislative process, whether it is the local committees, the council there, the municipal authority, it's at that level the budget gets approved. So when we do the budget approval process at a lower level, so the standard process ideally in a good practice should mirror the central government process, which means it's a bottom-up decision making, priorities are identified, annual work plans are prepared, and within the available resource envelope, that is, we assess the total revenues at the local government level coming from multiple sources. If I take an example of a council should be getting money, devolved money as a block grant from central government. If the state governments can usually, or provincial governments can provide funds, and they can have their own source of funding if assuming a particular function is in the mandate of the local government level. So within the taxing resources, assessing the revenue envelope, adjusting the work plans to fit into the revenue envelope, and getting it approved to the appropriate committees is a default process that a local government one follows. So it also depends on whether local governments also have in health sector, for example, lot of information in health which we try to collect through other sources like the assets and liabilities, the hospitals, the investments being made, which in a central government setup, which most of the time follows a cash accounting system, budgeting also being in cash accounting, lot of additional information is captured outside the budget and the accounting system. This is where in a devolved setting, it provides an opportunity, because most of the occasions a devolved government is a smaller level of government which tries to imitate and bring in a bit of accrual information. I use this word IPSAS in the slide, International Public Sector Accounting Standards. So whichever local council is using an IPSAS framework for accounting standards, accounting basis, budgeting gets strengthened also, because a lot of additional information is straight away available to the central level, to the council level, in form of approval information. So in this structure that we have in a decentralized setup, so the questions would be like, what's the big advantage of this devolved budget making process? The biggest advantage is expected to be twofold: bringing the decision making closer to the implementation, and two, giving flexibility to shift resources. So the more closer to the devolved level it is, the budget making, possibly the easier are the changes to be made. One question which many colleagues have in a devolved setting budget making process is line item budgeting, which means allocation of resources to individual line items, tables, drugs, computers. Is that a right approach, or a program budgeting approach a better approach? So each have their own advantages, but program budgeting has decisively a superior technical basis when implemented well in the local government level. But it requires a lot of preconditions in terms of like the predictability of cash releases and right alignment of program manager role at a decentralized level, without which program budgeting reforms at the devolved level may not work very well. So when we take this broader structure of budget, so we decide this devolution, the budget preparation, based on also to what extent the central level, because very rarely do we find in a lower middle income country the taxation powers of a local level for health services sufficient to cater to all the health services, even assuming the health as a function is completely devolved. So there is this requirement of this block grants or the transfers from the central government. How predictable these are, how timely these are, could be one of the key determinants of success of budgeting at a devolved level. PIFA, Public Expenditure and Financial Management Accountability Assessment, talks of how better to do the devolved budget transfer from the central level, but the decision space is based on this particular slide you're seeing. So the message here is, the narrower the range of functions, then you can have, like, depending on the choice of functions, the level of functions that are devolved, you can decide the scale of financing and decide the sources of revenues. So if you have a wide range of choices of sources of revenues at the local council level, obviously the level of intensity at which the budget process in local level will be much stronger. So when we club all this together, what is the mechanism through which this can work? Financial Management Information System at central level, what we call as IFMIS system. This is the means for making the budget and implementing the budget at central level. What about at the devolved level? Devolved levels usually have their own FMIS systems, whether they call them the same or not. And the budget preparation and evaluate and implementation is expected to be done through the system. So this structure, the ideal scenario would be the budget preparation at devolved level through the local IFMIS system need to also connect and have an interface with the central IFMIS system, so that the central government would also get the necessary information, and the whole of government, whole of health sector level information is available. The key in use of the IFMIS system is the multi-year commitment control. Many cases, if the FMIS system for budget preparation and execution is more used not in substance, but essentially in form. So ex-post entry of data is made. Commitments for which budget is not there are done outside the system. So once we do such kind of practices, the budget preparation and execution at local level gets affected. Multi-year commitment control is key in implementation of IFMIS at local government level as well. In summary, so what we see is devolution of health budget to local levels provides opportunities, which is very positive, bringing closer to decision making. But it comes with a lot of risks. The biggest risk are also related to the risks of ineffective oversight locally of the local governments and the civil society organizations. If the decision making at local level is not very effective and the oversight is not effective, it boils down to this money turning out to be slush funds flexibly being used at local levels, and a lot of wastage can also take place. So the devil is in the detail, how we devolve and how we make it work. Human resource development at devolved level for budget preparation is extremely important. Most of the subnational level, the PFM capacities are extremely poor, which adversely affects the budget preparation as a whole and health sector in particular. Success depends upon the local level administrative alignment. So how well the political and administrative alignment takes place with the fiscal devolution.
We will now turn to Martin, who will discuss the situation in Argentina with budgeting. Martin, over to you.
Well, as you may know, Argentina is a federal country, middle-income country. It is organized in 23 provinces and the autonomous city of Buenos Aires. Provinces show significant differences in terms of demographic, geographical, and socio-economic dimensions. The federal state is in charge of the vast majority of tax collection, almost 75%. The federation has wide discretion to allocate these funds, and the provinces and municipalities are in charge of almost 80% of health public expenditure. This asymmetry between taxation powers and expenditure responsibilities places provinces in a situation of permanent imbalance. The health system is composed of three sectors: the public, the social security, and the private one, that in practice are segmented according to people's income. We have universal coverage, but in practice there are significant access and quality gaps. The public system is highly decentralized and managed by the provincial and municipal levels, and as I said, it provides coverage to the whole population, but mainly to the poorest families. Today, almost 17 million people, that represent 37% of the total population, receive services from the public sector for free. And in this context, the Federal Ministry of Health holds the stewardship role and has a modest financing participation. Provinces instead account for more than 2/3 of public health spending. These funds primarily come from federal co-participation contributions that do not take into account health needs of the population, the performance of the health systems, and they are not earmarked. So each province is responsible for defining the percentage of its budget that will be spent on health, and therefore provincial health spending differs between provinces from less than 8% to 28% of total provincial spending. This public spending is concentrated in providers that deliver high complexity care. Spending on personnel is large and inflexible, around 60% of provincial health budget and close to 80% of hospital budgets. Provincial budgets use a programmatic classification by program, so program, project, activity, etc. However, budget programs, the link between budget programs and the final delivery of goods and service and performance measurement is limited or non-existent, which in practice means that do not operate as real programs. In 2004, the National Ministry of Health launched Programa Sumar that aims at transforming the public health coverage into effective coverage. The program aims to increase access to a health benefit package for people without formal health insurance by strengthening the purchasing function at the provincial level through a twofold RBF mechanism. In this slide, you can see that we have two relationships. The first one is between the federation and the provinces. In this relationship, the program utilizes a capitation payment linked to performance. 60% of these transfers are linked to the enrollment of the target population, and the remaining 40% is linked to the achievement of prioritized results that are measured every 4-month period. It is important to point out that provinces must co-finance 50% of these transfers, and the main motivation of this rule is that the federation wanted to align financial efforts and to encourage improvements in provincial PFM. Then the provinces, now I will describe the second relationship between the provinces and the facilities. The provinces can only use this money, these resources, to purchase a health benefit package to public providers using a fee-for-service payment mechanism. The providers have autonomy to allocate these funds that they can receive based on production to satisfy their specific needs, and this was critical in order to close the incentive chain. I could say that transfers are quite stable and predictable to provinces and to facilities as well. All these rules and results are audited systematically by an external auditor that is a private firm and whose opinion is binding for the federation and for the provinces, and this third auditor can apply sanctions and penalties for the provinces and the facilities as well. Well, from our experience, there are three key aspects when designing conditional grants. The first critical aspect is the method to define the size of the transfer pool. In the case of Argentina, the program covers the incremental cost of a health benefit package. It covers a share of the total cost of this benefit package, and the main motivation is to ensure financial sufficiency across provinces. Then the second key aspect is the allocation criteria. As I said, we are transferring resources, 60% linked to the enrollment of the target population that have received at least one preventive service in the last 12 months, and the remaining 40% is linked to performance indicators. And the third key aspect is the conditionalities for the use of funds. I mentioned that provinces can only use this money to purchase this health benefit package. So here you can see that we are trying to encourage improvements in the purchasing function at the ministry, at the provincial ministries of health. And as I said, they have to co-finance these capitation payments that every month and every 4-month period the federation do to the provinces. So with these conditional grants linked to results, we can say that the national government, the federation in a default setting can pursue multiple purposes. For example, these countries can introduce a common health benefit package, as we did it, focus on primary health care. These are tools that can make great contributions in order to equalize funds and to create the right incentives to the effective provision of a health benefit package. And of course, you can strengthen the purchasing function, you can broaden financial autonomy of providers, and you can make some contribution or initiate the agenda to improve PFM rules and practices at the subnational level. In order to encourage these changes and improvements, the National Ministry of Health through Programa Sumar has developed a strong control environment and have designed a financial penalties matrix. And here I have two examples that I would like to share with you. In terms of the specific use of capitation transfers, provinces must pay providers within a specified period, 50 days after receiving the invoice from the facility. The third auditor do the counter verification every 2 months, and we can apply debits and fines. For example, 20% of the debit amount for each service purchase that not fulfill the mandatory requirements, and we apply some fines too for each day of delay. So we are trying to enforcing the fulfillment of the program rules. And in terms of the co-financing duty, provinces have to make their disbursements within 15 days after the transfer from the Federal Ministry of Health has taken place, and this is audited by the internal verification, the internal team of the program, and by the counter verification as well. And in this case, we also apply financial fines if there are some delays in the fulfillment of this obligation, and further we can apply a debit if there is a long delay in fulfilling this duty. Regarding the direction of change encouraged by the Ministry of Health through Programa Sumar, well, we can see that before Programa Sumar, provinces used to program-based budgeting, but in practice they still continue to spend by inputs. Their priorities and goals were not reflected on budget. Providers were exclusively financed through global budget, specifically hospitals, and input and wages. The budget execution was totally centralized at the Ministry of Health and partially at hospitals, and it existed a limited accountability for what government intends to purchase. And since Programa Sumar, with the contribution of Programa Sumar, budget elaboration is based now partially on projections of services, the number and cost of services to be delivered to beneficiaries. In some provinces, we are identifying that they have started to define priorities and to reflect priorities in budget allocations. Provider payments are now based on outputs. As I mentioned, we are introducing a fee-for-service mechanism to encourage a better production, to increase the production of preventive services that are underutilization. And we broaden the financial autonomy of providers. Now they can capture resources, they can use them to satisfy their specific needs. And we did a great work to achieve that they can retain savings and surpluses every year. And finally, funds can be traced and linked to service utilization by beneficiaries. So these are some specific concrete contributions that the program have made to PFM architecture at the provincial level. Well, in terms of contributions made by the program at each stage of the budget cycle, we can say that in terms of revenue projection, now provinces are projecting their incomes based on beneficiaries with effective basic coverage and based on health output and outcomes. Every year, the Federation, in July, more precisely, informs provinces the capital value for next year and the performance indicator targets so that provinces can do their projections. In terms of budget elaboration, now budget is formulated based on health service projections that will be provided to beneficiaries. The benefit package is systematically costed by the Federation. It is annually updated. And in terms of the budget execution, as I have described, funds are now timely transferred to public providers every month based on their production. Providers have autonomy to allocate program Asumar funds. The provinces defines the expenditure categories and the facility decides which specific good or service to purchase. And this is very important because the facility may self-manage its own bank account. It is the exception, or it may be managed by a third party, a hospital, a municipality, or a province. And this third administrator have to purchase, must purchase, let us say, each specific good or service with the written authorization of the provider, and the third administrator cannot charge any commission. And finally, talking about the financial reporting, well, funds can be traced and linked to service utilization by beneficiaries and performance of facilities. And this is another important issue, that Provincial Court of Accounts are gradually introducing some changes in the way they audit budget execution and are placing now greater focus on performance. This is very important because it is very difficult to consolidate improvements on budgeting because control agencies use the old verification mechanisms. So in some cases they place more focuses on rule compliance rather than outputs and performance. So these control mechanisms should evolve with the new budget rules. It is important that the control agencies modernize their way of supervising, verifying budget execution. If not, it could become a great obstacle to improve PFM system. Finally, to conclude, I would like to share some reflections. The first one is that conditional transfers can make significant contributions to improve the health financing function and PFM architecture. Programa Asumar has initiated a fruitful dialogue with the Ministry of Finance and has created an initial agenda of concrete improvement in the PFM system. It is fundamental in this sense that to achieve a better understanding among health authorities of ongoing PFM reforms, and it is also important to achieve a better understanding among finance authorities of health financing policies and goals, and the role of PFM in their implementation. Then the effectiveness of conditional transfers depends on the coherence between the three key design arrangements. As I said, the method to define the fund pool, the allocation criteria, and the conditions for the use of funds. These three components are critical, the three of them. And of course, we have just initiated the improvement agenda for PFM at the provincial level. So to further improve budgeting processes in these provinces, it will be crucial that the Ministry of Health and the Ministry of Finance develop a joint work agenda. It is also key to align incentives and harmonize requirements between conditional transfers within the public sector, but with different sectors as well, with other sectors as well as education, infrastructure, etc. And finally, as Srinivas mentioned, change in budget formulation should be accompanied with technical assistance to provinces to strengthen local capacities. This technical assistance should be directed to the Ministry of Finance, to the Ministry of Health, and of course to control agencies that play a very important role in this regard.
We will now turn to Munge, who will talk about budgeting in Kenya. Over to you, Munge.
So Kenya underwent its most recent changes to decentralization arrangements about 6 years ago with the creation of 47 county governments. The changes resulted in a sharing of a number of functions. In terms of the health function, the national level retained the role of policy, standards setting, and the management of national referral facilities, while the county level took up most of the running of public health services from community level to the first level of referral hospital, but is also in charge of other determinants of health such as water and sanitation and public health services, and also monitors the standards of private practitioners that may be operating within county boundaries. In terms of revenue assignments, or who is charged with obtaining which revenues, the main source of revenues for the county level is the equitable share of national revenue, mostly because the national revenue retained most of the revenue generating role. The diagram shows you the composition of local revenues, and you can see that the equitable share contributes well over 80% for most of the counties, and these for the last 2 financial years. The formula that shares this amount does not cater well for health differences, but instead accounts for things like land surface area and population size. The Kenyan financial year runs from 1st July to 30th June, and the health sector annual operating plan cycle, which is shown in green in the diagram, is meant to synchronize with and feed into the budgeting process, which is shown in blue. The blue process is, of course, initiated and managed by the Treasury, and the green process is dependent on this, but is managed mostly by the health sector itself. So I have arranged this slide mostly to look at the consequences of decentralization in terms of 2 broad concepts. So one is in the changes in fiscal arrangements. So this is what we've discussed in terms of who does what and who has access to what revenues. And then the second change was in the government-citizen relationship. So ideally, decentralization should result in better accountability and better flow of information between citizens and governments and between actors at national or decentralized level. I'd like to focus on the legal framework for the budget and planning cycle, and also on 2 aspects of the budget cycle. So that's on budget preparation and budget execution, to illustrate what the consequences of decentralization have been in Kenya. So in terms of the legal framework, in 2012, the government introduced a comprehensive public financial management law that mandates program-based budgeting and also brings together a number of various laws that used to manage the public financial management process, which has improved clarity in overall. And what has resulted is that decentralized level budgets have moved from line item based to program based budget, at least in form, but not necessarily in substance. And that this has been referred to as, isomorphic mimicry, where things take on the form but not the actual substance of another. Some interpretations of this PFM law have also resulted in the reduced autonomy of county government entities, and this includes hospitals and health facilities, which has had implications for service delivery. This is a quote from a publication by Baraza et al., and it's titled Re-centralization Within Decentralization, and it looked at county hospital autonomy under devolution in Kenya. And this mid-level manager in a hospital is complaining that they have lost the authority to incur expenditure as a result of this new law, or the interpretation of the new law. The second area I wanted to look at was how decentralization has impacted on budget preparation. One of the things I pointed out was that there should be a clear distinction between who does what role, but in practice there's been quite a lot of overlap in performance of roles, leading to duplication in resource allocation, even during the budget preparation process. Another consequence has been that the planning process is not valued because the lack of clarity between who does what can mean that national level priorities and plans can override those of county planning officials. And overall, there's limited use of evidence in priority setting because that would require coordination between the two levels and clarity in who does what. Finally, there's limited evidence of citizens contributing meaningfully to the budget preparation process. A lot of the involvement has been quite cursory or to tick the box versus necessarily influencing the preparation of budgets, especially at the centralized level. And so you have this quote that is from a national level stakeholder, and they discuss the pull and push between the two levels that is still a feature of the Kenyan health system. And the respondent implies that this is because the National Ministry of Health is not focusing on its function, but is fighting with the decentralized governments to deliver services. The third area I wanted to focus on was decentralization's impact on execution. So by most measures, such as the absorption rate of the recurrent budget, there's been fairly high levels of budget execution, above 88% across the financial years. But this has been mostly because much of this budget is non-discretionary. It's spent almost entirely on salaries. And worryingly, there's not been a meaningful change in the overall level of public health spending since decentralization began. This is at about 30% of total health expenditure, with the other 2/3 coming respectively from out-of-pocket payments and donor funding. And in terms of health outcomes, some key health indicators are stagnant or declining. And the table there shows you what the indicators look like for the last 3 financial years for immunization, fourth ANC, and skilled attendance at birth, which are key functions of the county governments in terms of service delivery. So the key messages are that, decentralization has predictable impacts on planning and budgeting for health, as has been discussed by the previous 2 presenters. And as they highlight, strengthening public financial management is even more crucial in these settings. But there's definitely an opportunity to test approaches, as has been shown for Programa Sumar in Argentina, in terms of vertical grant design and implementation, but also other public financial management tools such as financial controls and frameworks for autonomy of subnational entities.
This is the end of our final podcast in our series on leveraging public financial management for better health. We hope that you have enjoyed this podcast series and will be able to utilise this knowledge towards better universal healthcare.